In the last decade, healthcare organizations have invested billions in quality improvement. New technology, new protocols, survey after survey, dashboard after dashboard. And yet, workforce turnover in healthcare has climbed past 18% nationally. Safety events continue. Patient trust, especially in Black, Indigenous, and rural communities, keep eroding. The question is not whether we care. The question is, why, with all this effort, are the same problems reappearing? Because we've been treating each problem in isolation, we address the workforce problem, then the operations problem, then the patient outcomes problem, separately, repeatedly. But medicine taught us something different. In clinical practice, we know that two or more conditions occurring together do not simply add, they compound. A patient with diabetes and hypertension doesn't carry twice the risk of a patient with one condition. They carry multiple risks because the conditions interact. The same logic applies to healthcare organizations. Workforce instability compounds operational drift. Operational drift compounds care variation. Care variation compounds inequity. And inequity compounds all of it. What if we applied the clinical logic of comorbidity to the organization itself? What if, instead of treating one system at a time, we diagnose the workforce, the operational infrastructure, and the patient outcome environment simultaneously, and mapped exactly how they compound each other? That is the insight behind HR CoMorb. And the tri-diagnostic it empowers. The HR CoMorb tri-diagnostic evaluates 3 operating systems in every healthcare organization simultaneously: the human operating system, the workforce conditions shaping leadership effectiveness, psychological safety, burnout, and identity alignment; the organizational operating system, the structural conditions governing workflow, throughput, governance, and resource distribution; and the patient outcome system, the downstream clinical effects, safety events, care variation, readmission risk, and the disparities that fall most heavily on Black, Indigenous, and rural communities. When all 3 are mapped together, the compounding patterns become visible. And visible patterns can be treated in the right sequence for the first time. Care disparities are not random. They are downstream output of compounding upstream failures that went undiagnosed. When workforce exhaustion is untreated, patients, particularly Black and rural patients, receive inconsistent care. When operational drift goes unaddressed, wait times lengthen and access inequities widen. When trust erodes, communities disengage from the system entirely. HR CoMorb identifies where equity is being lost inside the system, not as a diversity initiative, but as a clinical performance signal. Because for too many communities, the system has never been whole. The research is clear about what becomes possible when these compounding conditions are treated at the systems level. Turnover reduced by 15 to 30%, preventable safety events down by 20 to 40%, patient satisfaction scores improving by 5 to 15 percentile points. These are not promises. They are evidence-based benchmarks from peer-reviewed research, achievable when organizations are ready to treat the whole system. Well, HR CoMorb is launching, and we need your support to bring this triagnostic to healthcare systems, to clinics, and managed care facilities that are ready to stop treating symptoms and start healing the whole system. Your backing helps us deploy this framework where it needed the most, quite frankly, in the communities carrying the greatest burden of care disparity. Join the campaign. Help us make the invisible visible and the healable healed.